is where all our treatment for shock, because again, don't remember, shock is not low blood pressure. Shock is a decreased oxygen delivery to tissue. This is the definition of a shock. It doesn't mean that you have low blood pressure. It means that my oxygen is not going properly to my tissue. Why do we do a lactate in patient with sepsis? That's why. Because when you don't have enough oxygen, remember from your old good course from nursing, the cycle of Krebs, this is the cellular respiratory, this is what it is. So basically, if I do not have oxygen, I go from a aerobic circulation to an anaerobic. Anybody remember? If you have O2, what do you do when you do the cycle of Krebs? It's about 32, 36 ATP and about 2 H2O. If you do not have oxygen, what you create? Lactic acidosis and only 2 ATP. That's why we measure lactate, and that's why lactate is a great management. When you start doing your management of your shock, you measure your lactate, do a serial lactate. So if you're seeing your lactate going down, then you knowing that your therapy is going well, and you don't quite rely on the blood pressure as much as you're relying on your lactate. So you do a few lactates, and you're seeing if you're doing, because sometimes your pressure could be good, but for example, your guts is one of the last thing that your circulation will recuperate. And a lot of studies have shown that a lot of people, for example, when they were doing resuscitation, they would stop the resuscitation because their blood pressure was okay, but their guts were still underperfused. And what was happening is basically you were killing your guts. So you would have guts issues. So basically you would have necrotic guts and hypertension, stomach hypertension, and abdomen hypertension, and then they would have complications with it. So preload, afterload contractility. A lot of people will use this one and will act only on this one. So when you have someone that has a shock and have a low blood pressure, and you do fluids, that's all you do. But all the other shocks, that's not helping. You don't want to just give fluids. Fluids is not the solution to every. It is a solution in some issue, but not in every issue. Another mistake that a lot of people do is the Trendelenburg. And if you want, and I'll put a link down, there's a great studies and actually a position statement, I think, by the doctors, the Canadian Emergency Doctors Association. And what they were saying is that basically the Trendelenburg position is bad for shock. Lifting the legs, sure you can, but it is so much, and I'll let you read the position if I can find it and put the links there. But it is a bad position, and yet they still teach us is like when somebody goes, flip the beds up, flap it up, but you're putting too much pressure. So you can lift their legs if you want, and actually I think Red Cross now and a lot of first aid, that's what they teach their people. It's not so much to put their heads like this, but just lift their legs to bring a little bit the circulation. But it's to increase the preload. So let's clear that up a little bit, and let's go with the preloads, afterloads, and by the way, so now this video will be probably a two-part as I'm seeing now the time, but I think it's an interesting topic, so we'll do it. So sorry, but I like to listen to myself. Preload and contractility. Okay, so preload. Preload means the blood that comes before, well, basically, how much return do I have in my right atrium? That is the definition of preload. So how much stuff do I have in my things to start in it? And basically, you can ask yourself, when you get to someone in shock, 3 questions. Is it a pump problem? A vessel problem or a fluid problem. That's how easy it is when you go for a shock. And how to differentiate those, and how sometimes I do the demonstration of it is, think about, you have a glass of water, you have like those turkey basters on it, and then you have a funnel. This is your funnel, this is your turkey baster, and this is your glass of water. And this is what the issue is so if I transfer in, and then you have a pot somewhere else. So basically, if I take my water from, so got my glass of water, I got my turkey baster, and then I got my my funnel like this, and then I want to put it over here. So if this is empty, I can have the greatest squeeze I want over here, and I can have the big funnel. No liquid will go in. I don't have liquids over here. So this is my problem. So this is where I have to solve. I can have this glass fully full, this fully open, but if I don't give a good squeeze on my turkey baster, I cannot take that water out to bring over here. I don't have a good squeeze. Same thing. I can have the great water, great pressure here, but a very, very narrow funnel, and so then my fluid won't go over here, because don't forget that here it's time. So all this has to happen in seconds, right? Because, or a few seconds depending on what's your heart rate per minute. Because all this process has to happen, so let's say your heart rate is 100, all this has to happen 100 times a minute if your heart rate is 100 or 120 or whatever. So that's why greater your heart rate, fastest this process has to happen, less efficient it is, because I have to do this versus if I have a heart rate of 40, I can go like this, reflect, stop. And this is the reason we slow down fast AFibs for that process, or also for people with MIs. This is another reason. So that's why you see like that formula really explains a lot of the treatments that we do. Okay, so we got this. So now that we understand this concept, let's go back to what we were talking about: afterload, preload, and contractility. There we go. So fluids. So this is easy, give fluid. But again, the right fluids. You don't want to give too much fluids. A lot of literature out there now for concepts, for example, in trauma, penetrating for sure blunt, they're still debating about it, but about what they call permissive hypertension. And what permissive hypertension means is that in the pre-hospital setting, in our little setting, we're almost like a pre-hospital as well, because we're never really the definitive set of care for those sick patients. We're going to transfer them to another environment. So until they get seen by a surgeon that's going to put his finger or going to put like a tool or repair it, you don't want to put too much pressure on this, and you want that clot to form. Well, if I give 5, 6, 7 liters to those people and they're bleeding, what I'm doing is diluting their vessels. I'm creating hypothermia. Remember those 4 things that we were talking about? We're creating hypothermia because those fluids that we're investing in, that we're injecting in and giving as a bolus, a lot of time we don't warm them. And even if we warm them, by the time that they've been given, when they get out of the warmer, they cool down before they get into the body. And they can literally cool the person down. So we're cooling them, so we're giving them hypothermia, and we're diluting their vessels, and we're increasing their blood pressure, which that means that the blood, as is going to come out, is going to create more pressure on those vessels, and that clot that was like just forming a little bit, now I got a lot more pressure, boom, it's breaking, and that can bleed again. So that's why they talk about permissive hypertension, and I'll put another link on down to discuss a little bit more about permissive hypertension, the reason of it and stuff, and basically what you want, be able to feel a radial pulse and somebody is being able to talk to you. And that's what it is. All that's what you want for major trauma. You want that stuff. That's it. A lot of people will use blood pressure as a sign, so less than 100 and everything, but numbers don't mean anything. The numbers that really mean something in the preloads, there's two of them. The MAP, so that little numbers on the side, which is basically your systolic plus 2 times your diastolic divided by 3 if you don't have it, but you can calculate it. So you want to keep your MAP a little bit greater than 65, and in some cases greater than 90, and we'll talk about it in a little second, between 80 and 90. Or your pulse pressure. And pulse pressure is very easy to calculate. All you do is you take your systolic minus your